Good evening, everyone. Many thanks for coming for this Saturday evening for the endoscopic webinar. Myself and Mandy is going to be hosting this webinar. Now we are going to hand over to Joe today. So Joe, the floor is yours.
Yeah, thanks Bhuvna for the invite. Thanks Mandy for putting this all together. And it's great to share the sort of hour with Aziz as well. I think the question that's been asked for me is to just lay the ground for the subsequent talks, which are going to probably go into more depth about things. And I think the question was about UK concerns about minimally invasive and particularly endoscopic vein harvesting during the COVID pandemic. As you know, I work in Blackpool. We were one of the centers that originally started with endoscopic vein harvesting in 2007. And I'm quite pleased that we're collaborating with some of the other centers in the UK to probably have the longest follow-up data, which we're quite excited about. And Bhuvna has really done a lot of work in putting it together. Can I have the next slide, Bhuvna? I think to set the scene, I thought the first thing to do is figure out what we actually knew before the pandemic started. So I think the best paper I found was a review published in 2006 that really was a multidisciplinary group of people, and a lot of them had actually been exposed to the SARS virus epidemic before. And I think this paper about things that they had learned from that episode, predominantly from Hong Kong and China. And it actually included a multidisciplinary group, and they talked about the factors involved in aerosol transmission in sort of healthcare premises. Next slide, please. So I think before they went to details, they wanted to actually define, because there were a bunch of engineers, microbiologists, epidemiologists, and they felt the definition is airborne transmission is a passage of microorganisms from a source to a person through aerosols, resulting in infection of the person with or without disease. And they described aerosols as suspension of solid or liquid particles in a gas of different sizes. And I think the key thing about these aerosols is the fact that they actually have nucleus material, RNA material from these viruses, which are potentially infectious. And I think these were the three key things about defining an aerosol. And the next slide, Bhuvna. So it basically then went on to point out that the effect of an aerosol in a healthcare setting and how it is transmitted from person to another person. It could be from a patient to a healthcare professional, and it could be the other way around as well, is multifactorial. So it depends on a lot of things. It depends on which way the gravity is working, which way the airflow is working, whether the aerosols are large, whether they're small. And some of the things they brought out were the simple things like, ventilation, where the vent is mounted, whether it's ceiling or floor. And one of the other things that they pointed out, which is a big problem, was opening doors. And I'm sure all of us have been, reprimanded at some stage when we've opened the door that leads straight into theater. And this actually causes a lot of vortices and brings in air that then exchanges the direction of flow. And certainly our microbiologist in Blackpool, puts big stickers across all the doors that lead straight into the theater saying they should not be opened during a procedure. Next slide, Bhuvna. So, the ideal way would be that the fresh air comes in from below and the polluted air goes up from above. But as you know, most places have ceiling circulated air coming in from the top, and that actually isn't very nice. And you'll probably find that newer build theaters and newer build hospitals do take in this consideration, and they are probably the least likely to cause aerosols sort of floating around and cross-infection. And certainly some of the restaurants and some of the hotel industries are all looking at these sort of ventilation schemes to try and get back to business. But most new build hospitals and theaters will have this already fit in. Next slide, Bhuvna. So in conclusion, they basically came up with 3 points, and they said there are only 3 ways to restrict transmission of these diseases. One is, of course, to control the source of infection and to quarantine them and use isolation facilities. And we all know about that when it happened to us with the term lockdown. Obviously, that is the most effective way of trying to control any viral contamination of healthcare workers. The second one, of course, is to control airborne transmission routes by using the ideal ventilation systems, preferably using sliding doors instead of hinge doors, and obviously sealing the doors and windows that lead directly into the area. And I think the final thing they said was to protect susceptible individuals from transmission by using masks, gloves, and eyepieces. Thanks, Bhuvna. So basically, as you can see, at the end of the whole thing, it works out in simple 3 steps, which is to some extent what the government was trying to do and probably attempted initially. Now you can see, we probably weren't very good at taking on some of the advice that was already around. So the WHO very clearly on 29th of January 2020 was advising the use of masks in the community, in healthcare settings, in the context of this outbreak. But it's probably taken us about 4 or 5 months to really, take it on board in the UK and follow this sort of advice. So sometimes, the countries that actually had been exposed to things like SARS, etc., were probably quicker on the ball than we maybe had. Next slide, Bhuvna. So the other thing that caught us out, certainly in the UK, I think, and probably other countries, and it even caught the WHO out, to be fair, was that this virus was slightly unusual because we're all used to symptomatic transmission, and that was what was regularly seen with both SARS and the Middle Eastern respiratory virus. And I'm sorry this slide is a bit small, but I was trying to pack a few things in. But what really surprised everybody was the pre-symptomatic transmission of this virus, up to 5 to 6 days before the onset of symptoms. And even more concerning was the fact that some patients who were asymptomatic were also transmitting this virus. And this really came out even from the WHO only towards the end of March, early April. And that probably is what really caused quite a bit of concern, certainly for us as healthcare professionals. Thank you, Bhuvna. So this actually, the previous slide actually was published by the WHO on, I think, the beginning of April 2020. So you can tell that they themselves were actually caught out because until then, as you remember, people were being temperature checked and people were actually sort of isolated only if you had symptoms. And sort of towards the end of March, early April is when we realized that to some extent, you had to believe that everybody actually had the virus because some might be symptomatic, some might be asymptomatic, and some might be pre-symptomatic. Next slide, Bhuvna. I think around that time, so late March, the Royal Colleges all came together and they came up with a very good set of guidelines, and I must say it's very nicely put together. But the one guideline they came out which about laparoscopy was that they said laparoscopy should generally not be used as it risks aerosol formation and infection. And the SAGES, which is a Society of American Gastroenterological and Endoscopic Surgeons, had also offered that guidance, and hence the recommendation was actually to avoid laparoscopy. It said consider laparoscopy only in extremely selected cases. Now, this advice was then obviously extrapolated to cardiac surgery, where the only endoscopic procedure that's widely done at that time was endoscopic vein harvesting. And so I think early April, a general decision was made across the country in many centers that they should reconsider whether endoscopic vein harvesting should be done. Next slide, please. Now, the SAGES, they came out with further recommendations about 2 weeks after, so on the 10th of April, and they came out with the European Association. Next slide, please. And their view was the ability to control aerosolized virus during endoscopic procedures is lacking. So they recommended that all members should wear PPE. And I would go to the sort of number 4 thing, which was that endoscopic procedures that require additional insufflation of CO2 should be avoided if possible until we have better knowledge about the aerosolization properties of the virus. And this probably is where, there was concern with endoscopic vein harvesting, because some of the, like certainly the Mackay set has a closed tunnel with CO2 in it. And if the patient had viral particles in either the blood or subcutaneous tissue, which probably is rare, but it's possible, then there was a risk of aerosolization. So there was concerns about it at that time, and understandably so. Next slide, please. Now, the orthopedic surgeons, to be fair, at the same time came out with an article about what they would recommend. This was again around the middle of April, and I think if you read their articles, they are more worried about cutting bones. So if you go to the second point on their guidelines, it says, while doing bone cuts, use an osteotome or a nibbler rather than an oscillating saw. So, I mean, I think that they are quite nervous about any oscillating saw. And to be fair, in cardiac surgery, we use an oscillating saw right at the beginning. And that itself is a big aerosol generating maneuver. And personally, I think that is quite a concerning maneuver for all our patients. And understandably, it was something that a lot of surgeons were concerned. I know the cardiology group did recommend that patients who could benefit from PCI would be better off having PCI rather than surgery. And so, there was an element of people trying to suggest not having surgery at all if possible. Now, the orthopedic surgeons also went down that route. They said open surgery should be avoided, and if it could be done percutaneously, that would be the recommendation. Next slide, please. Now, this was an editorial that came out of the Journal of Cardiac Surgery. It is predominantly about aerosol generation in a cardiac surgical operating room. And what's interesting is the main sources obviously are during anesthesia. A big concern was transesophageal echocardiography, because obviously there is a lot of viral particles in patients who are positive, or in patients who are viremic in the sort of saliva and obviously in the esophageal area. So TOE was a concern, and a lot of valve surgery, certainly minimal access surgery, requires TOE, and that was going to be a concern. Now, when they come to surgical procedures, obviously any stenotomy, any sort of procedure where you're going anywhere close to the lungs, like thoracotomy, insertion of chest drains. And I think the big concern also is surgical smoke related to diathermy. And they also mentioned the blow mister during off-pump surgery, which also generates some amount of aerosols into the air. Of course, carbon dioxide insufflation is also mentioned. I don't think they mentioned endoscopic vein harvesting specifically, probably because it's probably not that widely used, where this actually came out from, I think, Asia. Now, the key recommendations was to try and minimize aerosol generation, which, their recommendation was things like smoke evacuation, obviously ideal ventilation, and then the creating of negative pressure environment, which I think most cardiac surgery theaters do have. And so we're quite fortunate that way. And of course, personal protective equipment to be worn by everybody. So these are the sort of basic and key messages that were coming out from all specialties at that time. Thanks, Bhuvna. Now, around this time, around May, so early May, we, as part of BISMIX, wrote to all our sort of surgeons that we were aware of, who were involved with both minimal access surgery and endoscopic vein harvesting. And we kind of made the point that endoscopic conduit harvesting and minimally invasive cardiac surgery have shown benefits to patients. And I'm aware Aziz is probably going to cover that in more detail later on. And I think what we felt was that in the hands of experienced surgeons, we thought it was reasonable to consider these procedures, as long as, people weighed it on a case-by-case basis, because what we didn't want, obviously, is inexperienced people doing it with, and certainly we were nervous about teaching people or learning on when you're wearing PPE and prolonging operations unnecessarily. So our recommendation was to allow experienced surgeons to decide on a case-by-case basis to carry on. And I'm pleased to hear that a lot of EVH was done by very experienced SCPs across the country. And I'm told that many of you just carried on doing EVH. And one of the things we would like to do as BizMix is to look at it probably in September, October. So we have about 4 months data to see if there were any specific issues or concerns that came up. Thanks, Bhuvna. Now, I think the takeaway message has to be we have to continue with safe practice. I think we have to presume all patients are infected, though I'm aware that we have these green pathways and amber pathways, and it is, hopefully more and more patients who are coming in on the green pathway are less likely to be infected. But I think my recommendation is to just presume that all patients are infected and take all the regular precautions. We need to be aware that any surgical procedure, cutting skin, using diathermy, using a sternotomy, or will have the potential of releasing aerosol, generating RNA into the air. I certainly think this is probably a good time to look at things like surgical smoke evacuators during diathermy. And I think certainly for EVH, this only point I feel at the time where you can aerosolize is probably when you do a stab and grab and you open into a sealed tunnel. My own experience has always been to put a wet swab around the incision. And I certainly, in open systems, I leave a wet swab around the entry point where CO2 is coming out, just so that the wet swab captures most of the aerosols and doesn't let it diffuse. But these are things that I presume people do and I would recommend you carry on doing, because even when COVID is gone, we certainly in cardiac surgery already suffered from tuberculosis, where Mycobacterium chimera was aerosolized from bypass machines. So we do have a history of, infecting patients, and we need to be aware that it can go both ways. Next slide, Bhuvna. I'm going to finish off my presentation with one of my favorite singers, who's probably the only singer who's won a Nobel Prize for Literature. And I think many, many years ago, he wrote this song called The Times They Are A-Changing. And his point was that you just have to keep your eyes open because things change very fast. And I certainly think even now the wheel is still in spin as far as COVID is concerned. We're learning along the way. And I think the key thing for us as professionals is to keep our mind open and just collect data. And I know Bhuvna is very good at this, and I think all of you SCPs should probably come together and, in 6 months' time, see what it was like to do EVH in the COVID era and see if either any patients got infected or any practitioners got infected or any theatre staff got infected. And that's something that I know we are very keen in BizMix also to support. Thank you very much for all of those of you who've joined us on a Saturday evening. And Bhuvna, once more, thanks for inviting me for this.
Thank you, Joe. Thank you so much. And I got a quick question. So as you need to go, we will take the questions. Everybody can unmute it. Whoever wants to ask question, please unmute it. So Joe, have you done any endoscopic during this period?
Yeah, so we didn't do any endoscopic vein harvesting for the month of April. Partly because we were not operating in our own theatre suite. We had been moved to an operating suite which was donated to us by the ophthalmic theatre, and we were not sure about the air flow, etc. So in the month of April, we did not. Come May, we had come back into our operating theatres, which had better airflow. And we had a big discussion among our SCPs, and we were quite honest about the possibility that, we don't know exactly what the effects are. But to be fair, all 4 of our SCPs were quite happy. And the general consensus was that if they did open the leg, there was a lot more diathermy, there was a lot more actual blood loss, and their feeling was endoscopic vein was probably less likely to aerosolize. So we've been doing it for May, June, July. So it's about 3 months. So we've been doing it quite a lot of cases. I'm not aware of any incidents, but we haven't actually done a sit-down review and look at patients and healthcare practitioners. But all our healthcare practitioners are now swabbed every week. And to be fair, we're not aware of anybody who's caught it during work.
Thank you so much. Every week in Wythenshawe, I don't think they are doing it. I've not been even swabbed.
Yeah, we're doing
Okay,
it
that is a good practice.
every week just to check if anybody seroconverts, or again, because of this thing about asymptomatic and pre-symptomatic patients, we're just trying to check. It's probably part of some sort of trial.
Okay, thank you. Anybody got any questions for Joe, please? Because Joe is on his annual leave and he has kindly came.
It's all right.
Hi, Joe. Just a quick question.
Thanks, Aziz.
Fantastic presentation. Have you stopped doing on the thoracic sites? Did they stop doing vasculobectomy? I run a couple of minimally invasive programs. You're very well known for a lot of the minimally invasive work you do. So have you stopped doing your minimally invasive micros and so forth? What are you doing at the moment?
Yeah. So actually, what was surprising, I myself caught COVID. So I was actually away for 4 weeks in April. So I wasn't at work. And so when I got back from work in the beginning of May, what surprised me was the thoracic surgeons were carrying on doing vasculobectomies, and considering they were stapling lungs and they were taking bits of lung out and re-expanding lungs and deflating lungs, but the cardiac surgeons were extremely nervous, and certainly the anesthetists were kind of anxious about TOE. So again, we had this long discussion when I got back, and I was quite pleased that some of the centers like Middlesbrough had already done a few in April while the COVID, pandemic was at its highest and lockdown was a thing. So we actually had a discussion as a team, and we also felt that we probably should be okay. And so May, June, July, I must say we've probably done over 20 to 30 cases between the three of us surgeons who've done minimal mitral, and certainly a lot of EVH. And touch wood, we've not seen any specific concerns. I'm aware that Enoch is planning to do a sort of questionnaire review sometime in September to just see how many centers stopped and how many centers still did it. But again, we came back to the point that we wouldn't recommend people starting at this time with PPE. And certainly we were very keen that people keep procedures to the shortest time, because anesthetists were already complaining about wearing masks for 4 or 5 hours. So if somebody is doing a minimal access procedure and is going to last longer, then we were quite concerned that might affect the morale more than the aerosol generation.
And are you now back up to normal, or is, in terms of the scope and the spectrum of surgical operations you do, and in terms of capacity as well?
Yeah, so we're not back to full capacity because our intensive care has now been divided into green intensive care for patients who come from home, who have self-isolated for 2 weeks. And obviously we have an amber side, which is where all the in-house urgents go. Now, the real problem, as you probably have found as well, is that a lot of unmet need has been developed in the last 2 to 3 months. So I think we have about 50 patients that are already in hospital. And so we're trying to do all the in-hospital patients through the amber side, and they nearly are all old and they're already in heart failure. So it's a bit of a struggle. And we're now to 3 theaters. We normally run 4 a day, but we're up to 3. But I think we're hoping to go back to 4, probably the end of this month.
Thank you.
Thank you.
Just to give you an update, we were similar. I can do it during the talk, but essentially in London, the 7 centres, as you may be aware, went down to 2, just Harefield and Barts. They were the designated what's called Plex centres. And all the work went to both of those centres. So I presume they're quite busy. I think Sam's there from Barts, so she may be able to update us a bit later about what happened at Barts. I've spoken to Alex Shipley a few times, so I did get a bit of a handle on what they did. At George's, we were completely decimated. Our ward suddenly became COVID, and in the March, when we still had patients on the ward had COVID patients. So we're actually doing ward rounds where there's cardiac patients and COVID patients. And slowly that our ward was taken over to become a COVID ward. Theatres got taken for COVID beds. ITU got taken for COVID ITU. So we completely lost everything. And I think for the second wave, hopefully it doesn't come, but I'm presuming they're going to go back to a model which we suggested some time ago, is keep one part of the hospital, which is like our self-isolated new wing, which is Atkinson Morley, as like a COVID-free part, and keep the main hospital as COVID, which most probably should have been done in the first place, but no one was sure what was going to happen. And I think that was the issue. But so hopefully from the next time we will have a service running throughout. In terms of capacity, we did nothing after, say, April, May, June. Then we started back up, 1 case a day, 5 cases a week. then went up to 2 cases a day. So we've been running 1 theatre a day, but that's difficult sometimes. Sometimes we get an extra theatre. Hopefully from the first week of September, we're going to go back to at least 2 theatres a day and up to about 4 cases a day. But similar.
No, I think anybody who did any work during this period needs to be congratulated because, it is a tough time for everybody. I think there are lessons to be learned, but everybody did a great job, I believe. And I think the harder job is going to be trying to catch up with the backlog.
Thank you, Joe. Any more questions for Joe before he leaves us, please?
If there are any, please just email Bhuvna.
Email.
She'll email me and I'll email back.
Thank you, Joe. Thank you so much.
All right. Take care.
Thank you. Okay. So thank you so much for everyone, whoever joined after Joe's talk. And good evening again. My talk shall highlight some of the points already Joe has discussed. However, I will talk more in depth about the aerosol generation and why the EVH is at risk. Okay. So the main objective of today's talk is about reviewing the current literature, the risk of viral transmission, and to propose a mitigation strategy, methods, what we can do, and how we can take it. So during this pandemic, everyone was asked to re-evaluate the approach about the surgical procedures. The main reason was about the fear of aerosol of viral particles. And again, the second one was the staff exposure to infections. Around March 2020, the International Society guidelines advised against the use of laparoscopic. And the main reason for that, but there was no evidence. And also the recommendations were based on the perceived cautious course of actions. Importantly, there were no literature about effect of endoscopic vein harvesting. So my talk is all about based on the minimally invasive surgery. So what do we know about coronavirus? This is an RNA-based virus, and the size can vary between 0.06 to 0.14 micrometers. Primarily, it affects the respiratory system, as we all know, but it can be found in many other tissues. It is a clear evidence that suggests that the S surface protein of the virus attaches to the ACE2 receptors, mainly the lungs and oropharynx. But however, the recent studies have suggest that it can be found in any smooth muscle, such as colonocytes to rectal endothelial cells, and also in the vasculature of the gastrointestinal tract. And there are some studies have found in the RNA in the stool as well, but in a minimal quantity. There are evidences that patients with coronavirus have elevated liver enzymes, but there are no direct injury to the liver. But most of them are, as we know, that they have a community acute pneumonia. So why minimally invasive surgery is at risk of aerosol? The main reason is the risk of surgical smoke. As we already talked about the infected patients with aerosol generation of intraperitoneal viral particles. So what really happens when we use electrosurgical instruments? Once the boiling point is reached on the tissues, the cell membrane rupture, generating a smoke composed of 5% organic vapors, particulate matter, cell debris, and 95% of water vapor. And many studies have proven for past 10 to 20 years, surgical smoke is more toxic than the cigarette smoke. And there are recent guidelines come by the NICE as well to use a smoke evacuator. And also the electrosurgical devices have been proven, and some Japanese studies recently found that bacteria and viruses such as HIV, hepatitis virus, and human papillovirus, now coronavirus, also can be found on the theta environment circulation. So as you all know that in from the Joe's talk earlier on March 2020, there was a guidelines came that sternotomy was considered as a aerosol generating procedure. But if you look at the current Public Health England guidelines, 23rd of July 2020 published, the sternotomy procedure is not on the list. If you can look at it, and it's only respiratory tract suctioning. I'm not going to all the thing, and also the patients who are intubating. There are lots of literatures. If anyone is interested, please look at the PubMed. There are lots and lots have been published as a fast track. The one literature what I want to talk about is a combined Italian and Chinese experience, mainly data collected from the Shanghai and Milan experiences. They talked about the 8 principles on preoperative, intraoperative, and postoperative period. Those 8 are general protections, mainly everybody needs to be health screened, whether they are symptomatic or not. Then prevention and management of the aerosol dispersal and management of artificial pneumoperitoneum. Operative techniques with electrocautery needs to be managed. Post-operative operating room and equipment management. Teaching and future recommendations needs to be written as a guidelines and needs to be published in the national and international guidelines. And operating staff protection with using occupational health protection of and also PPE and mainly preoperative health screening. As I'm not going to talk about the SAGE and EAR guidelines because that was released on 29th of March 2020 and soon it is due for revisiting. The main points they said that time was suspension of the non-essential surgical care of any type of surgery, testing all patients, consent discussion, dedicated COVID or endoscopy staff need to be used PPE, close smoke evacuation and filtration system, and minimize the use of energy sources, and pneumoperitoneum should be safely evacuated from the port, as Joe was discussing that using the wet swab is one of the good idea. Again, it's the same thing they were talked about like the Chinese one, personal protection, laparoscopy, safety measures, service rationalization, and use of minimal energy devices. So on 20th May 2020, the SCTS and BISCMIS statement came, endoscopic vein harvesting should be considered by the team and on the patient's best interest. So what did we have learned for? I know that my talk is almost quite similar to Joe, but what did we learn? In addition, any patients who are red on yellow category, they have to have an appropriate PPE in the theaters, patient isolation, and negative pressures. But however, we do not have any evidences that EVH possesses or do not possess any virus particles unless until patient is COVID positive. And also closing the small EVH incision with the port size and also using the smoke evacuator and filter can be better to reduce the viral transmission. What are the important steps we can take from this is using a closed circuit. Minimal, these are from, as I said, there are no guidelines available, but these are the cases what I have done. What I have taken the measure steps is minimum of 5 to 10 mm of inflation of air around the port, and also which will reduce the leak of CO2 outside to the air, and inflation pressure, keeping as low as possible 8 mm of Hg and flow rate of 1 liter. And what we need to conclude my talk, what we need to do is caution, 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 and meticulous preparation, especially for the patients who are on red and yellow category. Green category patients, recently last week, nice, I couldn't able to find the guidelines, but they say that if the patient is on green category, you can wear the normal mask in the theater after the anesthesia patient is being put in the ventilation in the closed circuit. And also, each individual needs to be thinking about the each institution policy, what they are saying, whether you are happy with that. That is the main thing. The practitioner needs to be comfortable with the technical approach they want to do, whether it's open, bridging, or endoscopic. You need to be comfortable. And what type of PPE, whether you want to wear it, you don't want to wear it, it should be an individual preference. Personally, I have carried out more than 50 cases, especially during the peak of pandemic, because we were continuing doing the cases in the private hospitals, even though our hospital were stopped for the COVID. And I haven't, or my team who I did endoscopic vein harvesting, and also my patients have not had any COVID infection yet. So the surgical technique should be considered to reduce the hospital stay with a reduced infection rate. Thank you for listening. Okay, we can take the questions later because I'm going to be here. So, Mandy?
Great. Do you want to continue with the slides, Bhuvana?
Yeah, of course.
Thank you very much. First of all, just thank you for for having me. I didn't think we'd get 144 people on a Saturday night either, so well done. This is not a Getinge event. This was all organised by Bhuvaneswari, so thank you. Yeah, next slide, please. So yeah, a lot of you, I mean, you've been there. This is no news to you what my slides are going to be about. Basically, it's I'm just coming from a company perspective. You guys have been operating there every day. Maybe my slides might be more interesting to the international parties to see the number of EVH cases being performed here and sort of the regions and what happened. Like we said before, we're going to speak to 2 London hospitals, St Bart's and St George's. Then at the very end, we'll open the forum. So most of you have probably met myself, Ganesh and Mel, but you may not know the whole team and who's behind the scenes. So we'll just start with top left with Gavin Ford, who's Managing Director of UKI and President of North Europe. Ken Boyle to the top right, who I report to. He looks after acute care therapy, so not only cardiac surgery, but a critical care division as well. So he's been under enormous stress during these times with ventilators and everything else. Ganesh and Mel have been superstars throughout this experience, helping where they can, and have also seen the challenges and also some positives as well. It's not all been doom and gloom. We've had some amazing outcomes as well, I think, during this time. Stephen Lowe, some of you might have spoken to him. He's a cardiac surgery customer service. So whenever there's any supply problem, you pick up the phone. Quite often he will answer. Again, he's been working from home. He's got a young family. Also done incredible. Deidre is our EVH sales in Ireland. So she's the whole of Ireland. And Megan is our marketing guru who you might have met at conferences. Who also this year, as you can imagine, we're a huge company. We had many conferences planned, which have all, like everything, gone up in the air the last few months. So she's also been run off her feet. So I guess a big thanks to everyone in our company. I am quite proud to say that, yeah, I think given the circumstances, I think we've all handled it quite well. Next slide, please. Yeah, so back, I think everyone's got a time when this first happened, the COVID, it's like, okay, how long is this going to last for? I think we all thought it would be maybe a couple of weeks and we'd be out of it, but a date that springs to mind for me was the 10th of March. For those that don't know, I had a baby last year, so I was off the whole of 2019. So I was back in January this year, ready to go. We had a sort of a major planning meeting, and everything that we had planned only a few weeks later was just from budgets to conferences to trainings to everything. So on the 10th of March, we had a face-to-face meeting with all the managers, and that was the last time we have seen each other throughout this pandemic, which I guess, I don't think we've ever worked in those kind of situations, which is the same as many people around the world. Next slide. Yeah, so I just want to rewind here to 2019 just to give everyone an understanding. Most people that are on this call from the UK, it's your hospitals, you're there every day, you understand what's going on, you know how many procedures we're doing. But for those that are overseas or not doing endoscopic vessel harvesting, hopefully this is interesting. So we've got the blues. This is 2019 cases per month. The blue is the London major hospitals. So normally a month in London, we'd have anywhere between 150 to almost 250 or 200 cases happening a month. And then down the bottom, you see that's a mixture of hospitals in the north, the Midlands, the south, and Ireland. And those sort of range between 0 to up to, just that's probably 75 cases a month. Okay, next slide. So if you have a look at this, the blue graph there is an amalgamation of all the slides before. So that's all the hospitals, procedures per month. If you have a look in 2019, roughly, it was, sort of 300 and then right up there to, 450 cases a month. And then you look at the 2020, as previous years, if you look beyond sort of earlier than 2019, year on year, we've seen huge growth with the uptake in the UKI. And that's what was tracking, I guess, for 2020. And then, as you all know, in April, it took like a nosedive. So cases went from 350 in January down to less than 50 in the whole country. So it was a huge impact to everyone. And yeah, you can see it looks like we've had a very sharp increase there, and this is the 2020 numbers. If you look, it only goes to July last month, and you would think, oh, well, okay, we're almost back to where we started, but I'll discuss later on in the next slides why that's looking like we're fully recovered now, or almost fully recovered, when we haven't really. But yeah, it's certainly a lot more positive than back in April, so we're all quite happy. So yeah, so back in April, you're all aware what happened. You guys are in the hospitals, and of the 50 cases that went on, they were mainly emergency. Now, when I say 50 cases, this is just the 50 kits that we have sold. Obviously, hospitals have their own stock, and this is just an estimate to see what's going on with their company. Some hospitals have, excess stock, so the numbers could be a lot higher. But then as Joe alluded to and spoke about in detail in the webinar, we had the guidelines, which then came out, and then it stopped some of our procedures even happening on the emergency patients. So it, yeah, we took a huge impact. Globally, I don't think they've had the same thing with the CO2, which is quite interesting. But yeah, we're very thankful for the BizMix and SCTS for writing the letter that they did in May, and yeah, we've had a lot of hospitals come back again, which is great. I think great for the patients. I can only imagine if you're one of those patients in April that were scheduled to have surgery, and then you can bumped and bumped and bumped. So yeah, then yeah, a lot of this stuff was spoken about before. The letter, the different ways that companies, like the Striker, for instance, they have, everyone's sort of looking at new ways to reduce the aerosol risk, which I think is important during this time. So yeah, next. Okay, so where are we now? The blue, what we see there is the London cases. So again, this is just from the start of the year to now. Let's look at London first of all, then I'll go through the others. You can see everyone is slowly getting back on track now. But like Mr. Moman mentioned, heart surgery in some centres totally stopped. Elective procedures were sent to Harefield and St Bart's. So those numbers that you see there in the blue, some of those are patients that were just, I guess, fortunate enough to happen to be redirected, and they ended up having endoscopic vessel harvesting instead of open, with hospitals that weren't doing EVH beforehand. So it'll be interesting to see in the next few months what happens there, and hopefully we don't have another spike, or hopefully if we do have another spike, hospitals are better equipped and can manage the whole scenario better, that these we don't have another April scenario again. Yeah, next slide. Everyone knows the challenges I spoke about before. Offices closed, warehouses closed, minimum staff everywhere. We've had the same battles as everyone, but yeah, new ways of working. Who would have thought on a Saturday night we'd have 144 people? We're all working here and getting educated. So yeah, I think it's a new world we're in right now. And yeah, and Mel and Ganesh as well. It was very, very difficult for them. They, from one day they're in a hospital supporting cases, training new staff, and then the next day, oh, are we allowed in? What's happening? And yeah, they've done phenomenal. And I alluded to a bit earlier, we've actually had some surgeons that patients ended up having endoscopic vessel harvesting that wouldn't normally have it in their hospital. And we've actually started a new Hammersmith Hospital, just started during this pandemic, which I think is wonderful. And who knows, maybe we'll have a few other ones come on board as well, just to help with the backlog. And if we can prove that patients are going home a day earlier, well, maybe this is now the time that more people will be adopting the technology. Yeah, next slide. Yeah, so education and training, I think our company, as well as many others, everyone now is on LinkedIn. They're all doing courses, we're doing these webinars. I think it's fantastic. I think it's great that everyone's on board here. And yeah, we're also learning. So let us know how we can help. We're always looking to improve things. And I guess the challenge is with our training that it's so important to have the clinical training, and that's why our clinical trainers are there every day. Till the harvester is proficient. And some of these harvesters have had 6 weeks off with doing no cases, and then they're back now, and and are we allowed access? Every hospital is different and have their own rules and regulations. So some hospitals fine, others not so much. So all those people out there, I'm sure, will be back training when we get the green light. So thank you very much. And I won't. Other programs that we've had of all, some people on this call I know were part of the radial harvesting one we had quite early on in the epidemic. We've had one since. We've got many other webinars coming up, and I think the plan is for this one to do another one later on, maybe in September, October, once everyone's back and recovered and operating as normal, and then to, like what Joe was saying, compare data and go from there. Yeah, so we all know the benefits of EVH, and I guess it's we want these patients out of hospital sooner. So yeah, we're just hoping that that we can start seeing these benefits again soon and get through all these backlogs of patients. Next slide. So now, Mr. Momin spoke earlier about St George's, but yeah, do you have anything else to say, Mr. Momin?
I'll just share my screen. Can you see my screen? Yeah. First of all, I'd like to say thanks to Mandy and Bhavna for inviting me. This was a little bit last minute because initially I was asked just to have a kind of like a conversation with Mandy and maybe a couple of sides from St George's, but I believe one of the speakers unfortunately couldn't participate today. So I tried to put a couple of slides to like encompass just not COVID, because we didn't do much operating during COVID, but we're back up and running in terms of EVH, and we've got quite a full program of endoscopic vein harvest with Terry, who's SCP, who's meant to be with us today, but he's unfortunately unwell as well. And we've got a very good endo-radio program as well. We've done a significant number of those as well now. And we tend to do a lot of total arterial with either endoscopic radial now or sometimes plus EVH. And most of the surgeons at George's now tend to use EVH. And I just want to share our experience, even pre-COVID, to show centers that are thinking about starting EVH or endoradial. And it was nice to hear that one of my old places I used to work at, Hammersmith, has taken it on board. And also that surgeons, that patients have benefited from COVID in London, where they may not have had EVH or endoradial, and now because they went to Barts and Harefield, they've had it. So, so the main person who I brought across from Hammersmith was Terry O'Connor, who's our lead SCP, and he came and trained with Mackay's support, with Mandy's support, to learn first of all EVH and then endoradial. Claire Bowles is our dedicated SSI nurse throughout, who's been collecting the data and keeping on top of the data. And I have to thank her for the data, the slides that we have today. And Matt Londy is my consultant microbiologist. So essentially, we had a problem when I first joined St George's back in 2013, and I'll show you the data. The SSSI rates were over 10%, sometimes reaching 13%. So then I organized a model of a complete model of care in terms of trying to reduce the infections. And this included pre-op, intra-op, and post-op. And one of the main components of the intra-op was to have EVH or endoscopic vein harvest. So we had to do a business plan and so forth and get it through the governance. But because of the data and the SSI rates, it gradually got through. And as you'll see when we started, there was a huge reduction with infection rates. But it was part of the solution, and then not the whole solution. You have to have a dedicated team. So we then had a weekly ward round where myself, the consultant microbiologist, and the SSI nurse, there was a different nurse at the beginning, and then Claire took over. We'd go around every week and check all the wounds. And then we looked for root cause analysis, especially for deep wound infections. And then we started educating. We started educating the nurses, the surgeons, the consultants, the registrars, the patients, the pre-assessment nurses about wound care, information on self-referrals. We wanted to know if the patient's going to have an infection to come back to us, not to go to the GP and get treated, because we felt if they come back to us, we can stamp on it quickly. Then we started looking at diabetic optimization. A lot of these patients had HB1ACs which were through the roof. See if we can get them better as long as they weren't urgent cases or critical left mains. Then we also now have added in IV iron, and we made sure that MDT, the whole team was updated and everybody went through AT&T as well. Now the plan is now to expand the endoscopic rate harvest. We're looking at appointing 2 more SCPs. We've had registrars and SHOs learn EVH, and we're now with Mandy and the team support, we're going to be training our new SHO. And when the next plan is to train some others on endoradio, because at the current time only Terry does that. And we look at wound pathways for high-risk patients, including positive pressure dressings. So lower rates of surgical site infections was our goal. We had monthly SSI meetings. It went all the way up to the trust board. When we first had the problems, we had the weekly ward rounds. We started EVH finally in June 2015. We added in patient staff education, support fest for sternum wounds, because we did a lot of bilateral mammaries and a lot of big patients and smokers. And we collected the data. This is the most important thing. You have to collect the data religiously, good and bad, and you'll see why as I go through the talk. In the SSI meetings, we had consultant surgeons, consultant microbiologists. We involved the matrons for theatre, cardiac surgery, CITCU, the ITU, representatives from the ITU, the ward sister, infection control nurses, cardiac surgery, nurse practice, and pre-assessment. We also at times had engineers, because I wanted to know about the filtering systems in there for the airflow and the laminar flow. And we had 3 monthly deep cleaning of those filters as well. And what was on the agenda? Well, we'll discuss any issues about infections, complex wounds, and root cause analysis, look for trends, what improvements should be made, and look at our compliance with NICE. We had these on a initially. Now we don't have them once we got it under control. Like I said, the SSI ward run is really important. It's 1 consultant surgeon, a microbiologist, nurse. Initially, it was always me. Now, the consultant of the week does it as well, but at times I'm still doing it as well. Review all patients with the SSI, ensuring optimum antibiotic therapy. Review the problematic wounds, whether they need to go back to theatre. If we have lots of deep or wound infection, we look at root cause analysis on each and every individual one, filled in by the consultants. Like I said earlier, staff education is important. Educate the patients not to touch the wounds, have lots of posters, especially now in the COVID era. Good daily hygiene, nutritional benefits, make sure they're well fed, strict blood sugar control, 48 hours post-op, keeping them on IV heparin, IV insulin if need be, if the control isn't good. And be on the lookout for wounds, even the basic things. We didn't change our wounds. We changed our wound dressings to a clear wound dressing so that it could stay on for 4 days and then take it off instead of daily changes. Oh, we cover with an op-site visible. Obviously, we'll change it if there is any oozing, and constantly doing ANTT and renewal of the staff competencies. And this includes all the surgical staff and the nursing staff. In terms of patient education, it started in the pre-assessment clinics, but even into hospital transfers, there was posters displayed on the wall to give patients about wound advice. And it was really trying to empower patients. One of the things I've learned in medicine, if you have a conversation and get the patient as part of the team, not as you're doing something, tell them that this is part of their journey. So some of the things I tell patients is, you need to start walking the next day after theatre. Don't touch the wounds. Take deep breaths. This gives them ownership of their own recovery wounds, and they tend to do better. And most of my patients go home on day 4 because of the EVH wounds or no wounds on the legs if they've had endoradial, and we try to get them going. We have a discharge coordinator who delivers an improved discharge flow, and now we've started taking photo and advice sheets given to patients who are high risk of developing wound infections, and they have a phone number to call on the ward, and we run a wound clinic. We don't want them going to GPs or having trouble accessing. We want to know the issues and hopefully sort them out ourselves. So this is kind of like a wound advice letter we would give the patient, and also the photo at discharge as well, if there's any issues from that point of view. These are the posters that we have on the wound that were designed. We have what they can do not lift anything heavier than a kettle, all the basic advice, but it's important that patients have this advice and know what to do. Dressings, like I said, it's basic, simple things. We audited the dressings. We actually now, the dressing is more expensive, but because we use so few dressings, we've actually saved money with this when we audited it. So initially the trust was a bit concerned that the dressings were more expensive, but over the audit, you can show you using less dressings, you save money and less infections. We added in for this larger patients post-op sternal supports, and this works very well. Gives the patient a lot of support, gives them comfort, and gives them a bit of confidence as well. In terms of, we're talking about EVH kits used and then non-EVH, and you can see in terms of the kits used and the non-EVH legs, SSI infections, you can see the numbers that we use. We've now pretty much gone to EVH, and the next slide shows remarkable. From 2015 to the end of 2019, we did nearly 1,000 EVH cases, and you can see we've got literally 8 cases in that plan if you add 220. So our infection rate in EVH cases is 0.6%, less than 1% wound infection rates. Tremendous. Some of them were hematomas, but this proves what a difference EVH can make. I think this is the take-home message from this talk. If you add in EVH to your program and you've got skilled SCPs doing it on a regular basis, you will bring down your SSI rates down to less than 1% for leg wounds, and the patients will mobilize quicker and get home quicker as well. And this is true of endoradial. I think we've done nearly 100 endoradials now, and as far as I know, we haven't had an infection in the endoradials at all. But Terry's collecting that data as well and hopefully present it at a future meeting. That's a quick run through. I know we're on a Saturday evening, so I don't want to take too much of your time.
Mandy?
So now we're handing it over to Sam. Sam Ibrahim, lead SCP from St Bart's Hospital, which is obviously one of the London hospitals which were active during COVID, seeing the most number of patients coupled with Harefield. But yeah, Sam, if you can give your views as to how you all coped, what happened from start to finish, and sort of where you guys are at now, that would be great.
So where do I start? It all starts from when we heard all about COVID nationally, and everyone was wondering what it is and how, what, where, why, and when. Obviously, it was a worry to everybody. Initially, because there were no policies and no one knew what kind of virus and how it was handled, etc. Only what was filtering through from the other countries, and people were reacting to that. And obviously, government guidance was the biggest thing here that we could talk about. How it affected us is, as Aziz said earlier, all theatres, all cases, cardiac cases were redirected down to, with the Plex system, down to Harefield and Barts. We remained very busy throughout the whole period, I must admit, okay? Even though the cardiac theatres did go down to 3, which is still the normal for a lot of other institutions, there were still thoracic theatres going on. And what we did do was, because we have 10 theatres, we were able to separate 2 theatres as COVID theatres. So anybody who did come in who was positive was not mixed into the other theatre groups, if you can understand. They were kept very separate. ITUs were separated. A lot of the staff were deployed elsewhere. A lot of anaesthetists, a lot of consultants, a lot of registrars were deployed. Obviously, there was the big complex out in Greenwich that I've forgotten the name. What was the name? What was the big complex they built out in?
The Nightingale.
The Nightingale. That's it. God, I forgot about that. And a lot of our directors and staff were deployed to help run that as well. So we did lose quite a bit of staff in that sense. However, we did still manage to plod on and carry on. In relation to EVH, which is what I was mainly concerned about, was we initially didn't have the article that came out about the aerosol procedures and how to reduce the CO2 in theatres. So when that did come out, it did impact on mainly the staff. Some of the staff were starting to get symptoms, not necessarily picked up from in hospital, but a lot was out in the community and from family members and other sites outside. So they were sort of isolating. So we were losing some staff in that sense. So what staff we had were sort of extra busy and working extra time as well. We continued doing EVH up until that article came out. I saw the article, I read it thoroughly, I looked at it, I showed the consultants, they were looking at it, but before we could do anything, a lot of the registrars did not want the EVH to continue in their theatres, because it wasn't the fact that the article made it clear that this is what it was that they wanted to protect themselves and the other staff in theatres from something that they're not 100% sure on. So they didn't want to take any risks or chances. So considering that, we stopped EVH for maybe about a week, maximum 2 weeks. And after that, we realized that we can't open legs. We can't do it. We couldn't. It was painful to do, painful to watch all these legs being opened. But having said that, we did not do as many CABG procedures as were doing on a regular basis. So
maybe explain how many you normally do. St Bart's is a huge hospital for those that are listening.
Yeah. We do 2, 4, 6, 8, probably about 8 a day, CABGs, if we've got the theatres there. I would say, all right, not 8, maybe about 7, I would say, regular. And if you times that by 4, that's per month, so 28 in a month. Sometimes more, because we did weekends as well, and then any emergencies that came in. So you're looking about 30, 35 a month that we were doing. And we hadn't slowed down until that article came out. And a lot of it was down to the nursing staff, registrars saying that we're not going to put anyone at risk because they weren't 100% sure as to what they were actually saying in relation to EVH and aerosol procedures. They didn't want to take the risk of doing the procedure without knowing. Then what I did was a lot of my SCPs, there's 13 of us, we sat down, had a meeting, and we said, look, we can't open the legs on a regular basis because it will increase our infection rate, which is, quite normal. It's what happens with open vein harvesting. So what we did was I went to the consultants, I went to the chief director, and I said, look, you've got to sit down as a consultant team and have a meeting about this, look at the paper that came out, have a look at it. This is what we're concerned about, and this is what you need to look at from your point of view and patient safety and staff safety point of view. Once they looked at that, a lot of the consultants were not agree that there was a very high risk when using the EVH. Because it is a closed procedure, it's minimal CO2 that's used, and we have a good filter system within theatres. The main concern was about intubation. Then there was this 20-minute waiting period, which everyone waited before they went in and did their own procedures. And not only that, PPE was used to the maximum. Everyone had fit test that works in theatre, and they had their own specific masks, and they were the masks, not the regular masks that you use in theatres, but the more fitted masks that reduce the intake and output of the staff in theatres. So all that PPE made a hell of a difference. And if you're in any of the theatres, the COVID theatres, you are fully donned, and that was 3 and 8. So those are the 2 theatres where you did the full donning. In the other theatres, we did PPE with the fitted masks and with your normal sterile gowns and things. And that actually made a difference and made the staff feel much safer, and even the SCP safer doing the procedure itself, if you see what I mean. Yeah. What happened after the 2 weeks was that the consultants came back and said, we looked at the paper, they think that it applied mainly to the VATS procedures within thoracics because it's a larger cavity that they're talking about, and it's an open cavity, whereas the EVH is a closed cavity, and very minimal CO2 is withdrawn once you've taken the vein out. Again, Joseph and Aziz spoke about the speed at which it's taken out, and touch wood, luckily enough, a lot of the SCPs now have been trained. I think there's only 2 that need training now, and they're picking up because we're doing so many. All of a sudden, their timing and their speed of EVH has improved and has picked up immensely, really well. So I think the maximum time, the longest time someone's taken to take 2 lengths of vein would probably be about 40 minutes, and the fastest would be about 20 minutes. So we're getting to that period where you could sort of say you're working in a safe space. Consultants came back and said they're happy for their patients to have EVH, and that the risk, as long as staff and patients and everyone is taking all the precautions necessary, then there shouldn't be a high risk at all. And if anyone is not happy to do it, then they're happy for that person not to be in that theatre and to swap with somebody who can. So the options were there. Luckily, we have enough people that we could make those options. So we were lucky in that sense. We did have a lot of patients from other hospitals, as you know, with the Flex project going on. And we had a lot of aortic surgery. In fact, quite a lot of aortic surgery came in. So a lot of all the elective cases had stopped. So we were doing emergencies only, and emergencies with CABG were a lot of board cases and patients that were coming in through our HAC system, which is our cardiac system that we run here at Barts. Elective cases had stopped, but the emergencies were still filtering through, and we had a lot of patients who were sitting on cardiology wards, who were waiting for bypass grafts as well. So they were slotted in, and we were doing them on a regular basis. They were more challenging because they weren't prepped beforehand, but we did still provide EVH. It has picked up again. We have picked up again since what month is that? July. I would say the 7th to 8th of July we picked up fully again. We now have 4 theatres running, and I think a couple of days a week we have 5 and 6 theatres running. That's cardiac. The thoracic is separate, and anything else is separate as well. So we're almost back up to our speed now. On Monday we've got 5 theatres, so we are quite busy.
And do you know what the hospital's plan is, Sam? If we have another spike, like down the track, will St Bart's take COVID patients again, or do you think they will continue to maybe get some of those elective, or it's all unknown? What's your?
We can take COVID patients again. ITUs, like they've discussed in previously, Joseph and Aziz were discussing. There's amber and green ITUs which we have, and we are lucky to have quite 1, 2, 3 ITUs that can cover the COVID. And they were absolutely separated completely on the 6th floor of our building. So they were nowhere near the cardiac theatres. There was no interaction, only to transfer the patients. Like I said, we have 2 COVID theatres. So we have certain routes that they follow within the hospital. They have to get to that theatre and follow it through, going out and back up to the COVID ICU. Now that we've gone since March, we've had all the experience that we have had in dealing, coping, all the issues, the concerns of people, staff, everybody, government, about the COVID within theatres and things and in hospital. I think a lot of lessons have been learned, and now we've been able to put things in place where that if we do get a spike again, theatres will not be closing down. Electives may reduce. It depends on the severity of the patient and the clinical condition of the patient, and they will look at that beforehand. Pre-assessment nurses are only doing patients that are self-isolating for 2 weeks, etc. I think most hospitals are doing these type of care.
It's great to have insight. Obviously, one of the largest cardiac centres in London and the UK. So it's great. Thank you so much.
Yeah,
no problem. Found it very interesting. I'll hand it back to Bhuvaneswari.
Yep.
Okay, thank you so much. Okay, let's take the questions, please. So what is your protocol for IV iron therapy in treating pre-op anemia? Ashish, would you like to answer?
Yeah. Essentially, what we do is they come to the state elective patients come to a pre-assessment clinic. So we run what's called a one-stop shop. I've been doing this for many years, but we formalized it a lot more for all the other consultants. We've been doing it 4 or 5 years. So they come in and they have the full bloods done, and we liaise with hematology. And previously they'd be put on iron tablets for some time, but now what they can do is we liaise with hematology, I a few weeks before to top up the iron. Anemia has been shown as a causal factor for post-op outcomes for these things, especially infections. I don't have the protocol at hand of how much IV I had, how many weeks before, because our pre-assessment nurses do that for us.
Is that cardiac disease?
As for, I know it's for cardiac. I don't know about thoracic because we kind of run the whole department separate because thoracics have their own pre-assessment nurses as well. So we used to only have one pre-assessment and 2 part-time, but recently they've expanded departments. So we've got now 5 of a lead as well. So we're well supported now. So I don't have to take such a hands-on approach at that point.
Yeah, good.
Because I was concerned, we had the people with HB1ACs of like 120, 144, which were huge, you know, and then we then started getting them in the community to get their insulin even better. And then once we got that controlled, then the next thing was the anemia with the hematologist. So it's just trying to make the patient's outcome better, the state of the patients. All these little things that add to bringing it. Like I said, there's not one silver bullet. One of the main silver bullets for infections is EVH, but you can do EVH and let all the other things go and use filter of infections.
Okay, Ashish, next question for you. Are you planning to publish your data?
Yeah, we will publish our data. It's just we need to write it up. I'm trying to get the endo radio data together, and then hopefully we will publish our data. As in, what are your rates of infection up in, say, Blackpool or Manchester or where you work, Governor?
So our rate of infection is very low because we started with the Sorin endoscopic in 2006 myself. I went to Munich to do the training. From 2006, we are doing endoscopic vein harvesting. 5 of us are already trained and we do it regularly. So the rate of infection is very, very low in our department. And we have, recently, I'm just writing out 49,000 patients of data. I'm just not finished yet. So soon we will be finishing it. Blackpool, Harefield, and ourselves. So we have total of 49,000 patients.
It's fantastic. So what is roughly your infection rate in that 49,000?
I'm not calculated yet. Just the data has been collected. Just we are putting it together. So hopefully I will put it all together soon. Any more questions, please? I know this is Saturday evening. Everyone would like to go on. The weather is really beautiful still.
Yeah.
So Mandy, would you like to say anything?
I just want to say, thank you very much. It's amazing how many people were on, and I hope everyone found it interesting. It's always it's hard from a company putting something together. I think no one wants to listen to us. You guys are the ones that are out there and doing the procedures every day and the real heroes in the story. So thank you very much. And I wouldn't have a business without the company wouldn't have a business without you guys. So amazing job, everybody.
Samira, have you got any questions?
Not at the moment. No, I'm just impressed with Aziz's data collection and stuff. I mean, everything he talked about, we do have all of that in place. The photo discharge is absolutely amazing. Just like yourself, Aziz, the infection rates once we started EVH went down to literally below 0.1. I think it was really, really low. I did do a little presentation within the hospital on that, and it made such a difference. And I just want it to continue making a difference. We're now trying to get the sternal wounds infections down because the leg wounds have sort of disappeared with EVH. But the only thing I will say with leg wounds, because we do have 2 surgeons that do open still, that they usually come back about day 25 to 30 from the community with problematic wounds. And it's just how they manage it out there. Like you said, Aziz, we take ownership of our own wounds. And sometimes it slips through, patients slip through the net and they do get treated outside and only come back to us when it's really worse. But I think EVH has made such a difference on vein harvesting that it should be promoted, it should be continued, and we can train as many as we can. I've got 2 more Mandy still to train. Wave, yeah, hint. But yeah, they're I'm just waiting for the chance for Mel and Ganesh to come back. So yeah. But thank you everybody for arranging all this. It's amazing, really good. Well done.
And hopefully we can have Harefield next time as well with their story, because they've also had a huge amount of patients through during this time. So they'll have some really interesting data, I'm sure, on COVID and how it has affected the cardiac patients.
Yeah. Just also to let you know, Aziz, also with the EVH, we've recently just been agreed a business plan to go on to the Pneumaclear with the filtering system.
Yeah, I just want to say that we use a ConMed filtering
Yeah.
system, which has and the CO2, and also we have a smoke evacuator, which
Yeah.
I attach to the CO2 system, and that
Yeah.
can be trialed. As I said, I have done almost 50 cases now,
Yeah.
starting from January, February, we started. And
Yeah.
I always use a small incision, very small incision, and I use 5 ml of port sealant, so
Yeah.
that will stop. And you can use a stab and grab, or you can use Ethicon grab system as well. And if anybody has any questions, please email me. Otherwise, thank you so much. Thank you for everyone coming. Thank you, Ashish, for coming in the last minute.